The person who brings an animal to a veterinarian is operating entirely on trust. They cannot ask the patient what's wrong. They cannot verify the diagnosis. They cannot confirm that the medication administered in the exam room is the medication written on the invoice. They can read the label on the bottle they're sent home with, but they have no way to know what happened in the treatment room before they were invited back in. The veterinarian speaks, the owner listens, the owner pays, and the animal, the one for whom all of this is supposedly happening, cannot report what it received. In most cases, the system works. The diagnosis is honest, the treatment is appropriate, the medication is what it claims to be. In most cases, the people who choose this profession chose it because they care about the animals in their exam rooms. This case is about what happens when one of them decides that the animal's inability to report is not a vulnerability to protect, but an opportunity to exploit. My name is Daniel Rowe, and this is the case that took me the longest to put down. Not because of the money, because of what was asked of the animals that couldn't object. The client was a private equity group called Hartwell Partners. They had acquired a regional veterinarian network 2 years prior, 6 clinics across the Denver metro area operating under a single brand, PetCare Plus. The acquisition was part of a broader consolidation trend in veterinary medicine, independent practices being bought by investment groups, standardized, and run as portfolio assets. Hartwell had paid a significant multiple for PetCare Plus based on its revenue history and client retention numbers. They expected margin improvement through operational efficiency. What they found instead was margin that wouldn't move. Their operating partner, a man named Dennis Holt, who had been installed as CEO after the acquisition, came to me through a healthcare operations consultancy that had worked with Hartwell on other portfolio companies. Dennis was methodical and direct, with the particular frustration of someone who understands numbers well enough to know when they don't add up, but not well enough to explain why. Our pharmaceutical costs are running at 22% of revenue. The benchmark for a practice this size and mix is 14 to 16. That gap has been consistent since we acquired. We've looked at supplier pricing, it's competitive. We've looked at treatment protocols, they're standard. The only variable we haven't been able to examine directly is what's actually happening between the prescription and the dispensing. Who controls pharmaceutical procurement and dispensing across the network? Our chief of veterinary medicine, a man named Dr. Pruitt. He's been with PetCare Plus for 9 years. He was there before the acquisition, he came with the deal. He manages the formulary, approves all drug purchases, oversees dispensing protocols. He has more institutional knowledge about the clinical operation than anyone else in the organization, which is also why we haven't been able to look at what he does without him knowing we're looking. What's the dispensing documentation like? Are prescriptions and dispensing records matched at the unit level? That's the gap. The practice management system tracks invoices to clients and purchase orders to suppliers. But the middle layer, what was prescribed, what was actually pulled from inventory, what was administered or dispensed, lives in the clinical notes, which Pruitt staff controls. We've never had a full reconciliation between what we bought, what we prescribed, and what we invoiced clients for. It's never been done because nobody thought it needed to be. Nobody thought it needed to be. In 9 years. In a business where the product being sold was medication administered to animals whose owners had no way to verify what they received. I told Dennis I'd need access to the practice management system, the purchasing records, and clinical documentation, and I need a cover that put me close to the pharmacy operation without alerting Pruitt. He offered me a role as a pharmaceutical inventory consultant, someone brought in to assess whether PetCare Plus was getting competitive supplier pricing and whether their inventory management could be tightened, the kind of engagement Pruitt would find mildly annoying but professionally unremarkable. This time my name was Daniel Webb, pharmaceutical inventory specialist, background in veterinary and human healthcare settings, brought in to assess purchasing efficiency and inventory controls, the kind of person who counts things, who asks where things are and where they went, who has a clipboard and a spreadsheet and a mild, persistent interest in reconciliation. Dr. Pruitt met me at the flagship clinic in Cherry Creek on a Tuesday morning. He was 56, compact and precise, with the efficient manner of a clinician who has spent 30 years moving quickly between exam rooms. He was not pleased to have me there. He communicated that through what he didn't say rather than what he did. He was cooperative in the way that someone is cooperative when they have no choice and want you to finish and leave. I'll give you full access to the pharmacy and purchasing records. I'll have my clinic managers brief their staff that you're here. I'd ask that you not disrupt treatment schedules. Our patients are our priority. Our patients are our priority. He said it with the conviction of someone who had said it many times. I noted it and moved on. The Cherry Creek Clinic was the largest of the 6, 12 exam rooms, a surgical suite, an in-house pharmacy that stocked approximately 340 distinct pharmaceutical products. The pharmacy was managed by a licensed veterinary technician named Rosa Medina. She had been at the clinic for 4 years. She was efficient, knowledgeable, and clearly accustomed to Pruitt's way of operating. I spent day 1 doing a physical count, every product on the pharmacy shelf against the inventory system. This was my stated purpose, and I executed it exactly as described, methodically, room by room, product by product. It was also the cover under which I built my first picture of what the inventory actually contained versus what the system said it should contain. By end of day 1, I had identified 3 categories of discrepancy. Products where physical stock was higher than the system showed, suggesting purchases that hadn't been logged or returns that hadn't been processed. Products where physical stock was lower than the system showed, suggesting dispensing that hadn't been recorded or shrinkage. And a third category that I hadn't anticipated, products that were physically present in the pharmacy but weren't in the inventory system at all. 11 products, not small quantities. On the shelf, unlabeled as to source, not in the system. I photographed them, noted the lot numbers, and said nothing. On day 3, I got access to the practice management system and pulled the prescription records for the previous 18 months across all 6 clinics. A veterinary prescription record should contain 4 matching data points: what was prescribed, what was dispensed from inventory, what was invoiced to the client, and what was purchased from the supplier to replenish stock. In a well-controlled system, those 4 numbers track together. Prescriptions drive dispensing, dispensing drives purchasing, purchasing restores inventory. The cycle closes. At PetCare Plus, the cycle didn't close. I built a reconciliation for the 12 highest cost pharmaceutical products in the formulary, drugs where the unit cost was above $50 and the prescription volume was significant. These were the products where a substitution would generate the most value: oncology supportives, specialty anti-inflammatories, certain antibiotics used in post-surgical protocols, a cardiac medication for dogs used in chronic management. The pattern was consistent across all 12 products. Clients were invoiced for the prescribed product at the prescribed product's price, but the inventory drawdown, the actual reduction in stock that should correspond to dispensing, showed a different product being pulled: a generic equivalent, a lower cost alternative, a product that cost 30 to 60% less than the one on the invoice. The client paid for the branded specialty medication, the animal received the generic. The difference between the invoice price and the actual cost of what was dispensed went somewhere that wasn't Hartwell's accounts. I ran the numbers for the 18-month period across all 6 clinics. The aggregate overcharge, the difference between what clients were invoiced and the actual cost of what was dispensed, was approximately $430,000. $430,000 charged to people who brought sick animals in and trusted that the treatment on their invoice was the treatment their animal received. But the substitution scheme was only half of what Pruitt was running. The 11 unlabeled products I had found on the pharmacy shelf on day 1 stayed in my notes. I returned to them on day 5. I ran the lot numbers against the supplier records. All 11 products had been purchased by PetCare Plus. They appeared in the purchasing history, but according to the inventory system, all 11 had been written off. Written off as expired, damaged, or unusable. The write-off records existed. The approval signatures on the write-offs belonged to Dr. Pruitt. He had approved the write-offs, he had taken the products off the books, and then he had kept them on the shelf. In a veterinary practice, a pharmaceutical write-off should result in one of 2 things. The product is returned to the supplier for credit, or it's disposed off through a licensed pharmaceutical waste handler. There is a paper trail for both. I requested the disposal records and return logs for the previous 24 months. The disposal log showed entries for most written-off products, but when I cross-referenced the quantities disposed against the quantities written off, there were gaps. Products written off in quantities of 50 units with disposal records showing 30 units, a difference of 20 units that was neither returned nor disposed, but also no longer showing in inventory. The 11 products on the shelf were part of those gaps. Written off, not disposed, still present and being dispensed or sold outside the official inventory system. Pruitt was dispensing written-off product, in some cases genuinely expired medication, in others product that had been written off for administrative convenience and was still within its use-by date, pulled from the books to create off-book stock that could be dispensed without generating a purchase cost. Either way, he was billing clients at full price for product that had already been expensed, already absorbed as a cost by the business and keeping the revenue. The write-off scheme and the substitution scheme were parallel revenue streams. One replaced expensive product with cheap product and pocketed the difference. The other eliminated the product cost entirely and collected the full invoice price. I needed to understand how the money was moving. The overcharge on substitutions, the gap between the invoice price and the actual dispensing cost, should have been visible in the accounts as margin. PetCare Plus was collecting more from clients than it was spending on product. That excess should have shown up as profit, but Hartwell's margins weren't improving. The money was leaving. I looked at the supplier payment records alongside the purchase orders. PetCare Plus used 4 pharmaceutical distributors. 3 of them were national, standard industry relationships with competitive pricing. The 4th was a smaller regional supplier called Mountain West Vet Supply. Pruitt had added Mountain West to the approved supplier list 18 months after the Hartwell acquisition, approximately 2 years ago. Mountain West pricing was above market on every product they supplied, not dramatically, 5 to 12% above the national distributors on comparable items, enough to erode margin without being obviously wrong to someone reviewing the accounts at a summary level. The excess cost across Mountain West purchases over 2 years was approximately $160,000 compared to what the same products would have cost through the national distributors. I ran Mountain West Vet Supply through the Colorado State of Secretary of State's Business Registry, registered 3 years ago. Registered agent, a filing service. Manager listed in the initial filing, a person named Carol Pruitt, Alan Pruitt's wife. The structure was now complete. Pruitt was overcharging clients through substitution, billing for premium product, dispensing generics, pocketing the difference through mechanisms I still needed to fully trace. He was double billing through written-off stock, collecting full invoice revenue on product that had already been expensed, and keeping the revenue. And he was running a supplier markup scheme through Mountain West Vet Supply, a company his wife owned that extracted additional margin in the business through above-market pricing on legitimate purchases. 3 streams, running simultaneously, for at least 2 years at their current scale and likely longer in earlier forms before the acquisition gave him the volume to expand them. The cash from the substitution and write-off schemes had to be going somewhere physical. I looked at the client payment records. PetCare Plus accepted credit cards, checks, and cash. Cash payments were logged in the practice management system, but the cash reconciliation between the system log and the actual deposits was done by clinic managers who reported to Pruitt. I requested the cash reconciliation records for the previous 12 months. There were 31 instances where the system log showed a cash payment and the deposit record showed a smaller amount. The total gap, $62,000 over 12 months. Not recorded, not deposited, gone.
On day 12, I did something that required Hartwell's cooperation and a licensed veterinarian they retained for the purpose. I pulled a sample of 20 treatment records, cases where the invoice showed a high-cost specialty medication and the substitution analysis suggested a generic had been dispensed instead. For each case, I requested that the pharmacist review the clinical notes, the dispensing record, and where possible, the lot numbers of product noted in the treatment record. Lot numbers are the key. Every pharmaceutical product has a lot number assigned at manufacture. If you know the lot number of the product dispensed, you can trace it back to the specific purchase shipment, and from there to the specific product that was actually in that bottle. If the lot number in the treatment record corresponds to a generic product in the purchase history rather than the branded product on the invoice, the substitution is documented at the unit level. In 14 of the 20 cases, the pharmacist was able to match the lot number in the clinical notes to a specific purchase. In 11 of those 14, the lot number matched a generic or lower cost alternative, not the product named on the client invoice. The substitution documented not just as a pattern in aggregate data, but as a specific traceable event in a specific patient's record. The pharmacist also reviewed the write-off products I had documented on the shelf. She confirmed that 3 of the 11 were past their manufacturer expiration date. The remaining 8 were within date but had been written off as expired, a false write-off that created off-book inventory. 3 products genuinely expired, being dispensed to animals and billed to their owners at full price. I noted that in the report as a separate clinical concern, distinct from the financial fraud and requiring separate notification. Animals that had received expired medication might have received ineffective treatment. In chronic management cases, the cardiac patients, the oncology supportives, ineffective treatment over a period of months could have had clinical consequences that the owners never connected to the medication because they never knew the medication was wrong.